Hello again, everyone, and welcome to this just-in-time training update. When we last met about 8 months ago, we were cautiously optimistic that we would be celebrating July 4th with our friends and family. Moderna and Pfizer were seeking FDA approval for their vaccines through emergency use authorization, and in fact, the first person was actually vaccinated during the recording of our video. Since approved, over 170 million Americans, or about 52% of the population, have been fully vaccinated. Spring brought the end to many COVID-19 mitigation strategies like social distancing and wearing a mask, and we started to return to some normalcy. Spring turned into summer, and where you're seeing record high infection counts once again, hospitals are at max capacity, and EMS systems are seeing record call volume. We have a new Delta variant, and there's ongoing discussion about whether or not we need vaccine boosters. We also realize there's a lot of noise out there concerning all of these topics, so we thought it was time to gather our experts again to give you the facts based on the latest data. We want to talk about what the data shows and what the data doesn't show. And so once again, we're about to enter the no spin zone. Today, we're joined by the Chief Medical Officer and EMS Director for Wake County, Dr. Jose Cabanas, Wake County EMS Deputy Medical Director, Dr. Jeff Williams, and Chief Medical Officer for ESO, Dr. Brent Myers. As a reminder, all are board certified emergency physicians with public health training. Welcome, and thank you all for joining us once again. So, Dr. Cabanas, we'll let you have the first word and get us started here today.
Thank you, Don, and again, thanks for Jeff and Brent for obviously being available to keep the communication, the education going. Friends, colleagues, as you all know, we are again in a rapid surge, a rapid spread of COVID disease due to the highly contagious Delta variant across the country, across our state, but also across our region and our community here in Wake County. And we are not immune to that rapid spread of disease that we continue to see. And as Don stated in his introduction, this is why we were feeling some sense of normalcy when things sort of drove down, but we're back to the rapid surge of cases in the community. So obviously, with this rapid spread of disease, we are seeing in our surveillance metrics a rapid increase of influenza-like illness activity in the emergency departments and also COVID-like illness activity, which sort of makes sense. We are seeing patients that are of a younger age, higher, that are unvaccinated and needing in-hospital care. Wake County has seen a rapid increase of hospitalizations across our community. As a reminder, our hospitals don't actually serve just obviously Wake County residents, but also the entire region. And we know that most of the patients that are requiring this higher level of care in the hospital setting are patients that are mostly unvaccinated. Now, our community, on a good front, past several weeks, we have seen an uptake on vaccination. And happy to share that as of August 24th, Wake County has a 60% fully vaccinated across our community. But my friends, we have work to do. We have more to grow, because the more we can get more people vaccinated, they will be protected from severe illness. They will be protected from needing hospitalizations, and can also relieve some of the pressure that we're seeing from a hospital and EMS system capacity standpoint. We do know that there's still questions about vaccination. There's still questions about why are we here, breakthrough cases, and we wanted to now take a deeper dive into sort of the vaccination sort of understanding and remind folks why vaccination is helpful. So with that, our good friend, Dr. Myers.
Thank you, Jose. Blaise Pascal once said that I've only made this letter longer because I didn't have the time to make it shorter. Not that the story need to be long, but it will take a while to make it short. We had a long story to tell 8 months ago. There was a lot that we didn't quite know. But the story right now is incredibly short. And the story is very simple. Vaccines protect against all known variants. No debate, no question. The science is 100% solid about that. And I just want to be clear, We know how vaccines work. So the notion that these vaccines, came out fast or whatever, that's no different than we came out with a new antibiotic and we rushed it because there was a new infection that came to market. We know how antibiotics work. This is a very simple thing. So I've found it interesting when folks have a conversation about this drug and how it's emergency use versus now one is FDA approved, yet when they contract the disease, they enter a hospital and receive tremendous numbers of drugs that have various FDA approvals, and nobody seems to be arguing about that. So this notion that we don't know how this works or what we were doing with the vaccine is just not borne out by fact. All we need for a vaccine to work is to show a protein sequence to the body's immune system so that it knows what the enemy looks like. It's just that simple. And we found a very simple way to do that with an mRNA vaccine that doesn't change your DNA, that leaves your system. All of those things are very clear now based on the number of patients that have been vaccinated. So there is no question about how this works. We're serving up a protein so the body can recognize the enemy. Just that simple. So I do encourage us, when we look at what's portrayed in the media, to ask ourselves the question, what are they actually talking about? So for example, in some of the cases that you see where there's a breakthrough infection with a vaccine, these are people that are being tested on a daily basis and they happen to get a positive test. So the governor of Texas is a prime example. He's tested all the time. He happened to have a positive test. As far as we know, he never developed a symptom. If he did, it was very mild. But he just happened to get tested. But that's a quote unquote breakthrough because the virus could replicate briefly before the immune system took over. So I would argue that all of these, where hospitalization rates and death rates are similar to other diseases, mean the vaccine is working. The whole purpose for the shutdowns and everything else we did was the last two lines, which is hospital disease limiting resources and death more than expected with other diseases. And I will posit and we'll show in the data, the vaccines are protecting against all of that. So when you see things in the media, you have to know what is a breakthrough. How do they define it? Is it just a simple swab? Is it somebody had a mild illness, the COVID cold, if you will? Or is it someone that actually required ICU stay and hospitalization? So I encourage you to look through that.
I want to talk about breakthrough infections.
Yeah.
So the original studies that were done to get the emergency authorization never said that people wouldn't get disease after the vaccine. It said it would limit your hospital course and or death, right? So this notion of a breakthrough thing, the media likes to talk about it a lot and blow it up. And people think of it as a new thing, but it was always there. It just really wasn't focused on. Is that right?
Yes, that is correct. And when you look at those original research studies that were done, many of them only tested at symptoms, right? So there may have been a lot of folks, and you remember when this first came out, one of the questions that came up is, are people who are vaccinated still capable of transmitting the disease, right? And immediately that question was asked because we didn't do the very first line here for every patient that was vaccinated and just randomly test them for this disease. So I think you're exactly right. And if we go back to, don't change the slide, but just go back to that slide about how vaccines work, they show your body what the enemy looks like. The enemy can still set up shop. The difference is it sets up shop very briefly because we recognize it fast and clear the infection, as opposed to this de novo, we've never seen the enemy before, and it really has set up camp before we can mount a response. So one other thing to think about here, name another disease where we run around in the community and stick swabs up people's nose to see if it's detectable, right? The fact that we have such readily available PCR tests is fantastic, but it also limits our ability to compare it to previous disease outbreaks, because the flu vaccine is probably very similar to this. If we went running around checking PCR for flu all winter, we would find a lot of asymptomatic vaccinated people, which is academic interest, but is not of interest to your personal health.
No, and I think that's a good point, because people think that breakthrough infections, just came out of the blue all of a sudden. But that's not necessarily the case because we stopped testing people for a period of time who had gotten vaccines. So there may have always been this breakthrough cases in the community. We just weren't testing for that and reporting that data.
That is correct.
Yes.
And as we'll see, the other difference is, the Delta variant does change this too, right? Just because of its increased transmissibility. It doesn't appear, quite frankly, that it's a more severe disease. It just appears that it's like 10 to 12 times more transmissible than the previous variant. So there's another kind of confounder in there, but you're exactly right. There had to be asymptomatic carriers all the way through.
That's correct. I would also just to like was mentioned before, for people to remember, vaccines will protect you from severe illness, not from having a little bit of a COVID exposure, mild disease course. And that is the goal, right? The goal is for you or for somebody not to end up in the hospital needing high level of care or needing to be in a ventilator. So yes, vaccines doesn't mean it was not designed to be 100% you will never get COVID, but it was to be highly effective preventing severe disease course.
I got two analogies I've been working on. Now may or may not be the right time to deploy here. So when you think about vaccines, you can think about a race, right? Think about a marathon. And I was going to do this a little bit later during my slides, but since we're talking about it here, we'll go ahead and say it now. If you're running a marathon and you're unvaccinated, you're going to start at the start line and you're going to have to run, to the finish line. If you're vaccinated in the race against COVID, you get to start about halfway, right? It's not saying you don't have to run the race, because you do have to run the race, right? It's not saying that you're not going to get beat, right? There are people who are vaccinated who are hospitalized, and we're going to talk about that, right? But it's saying that you got a really good head start, right? It's saying you got a really good head start and you got an advantage versus all the other vaccinated people, all the other unvaccinated people that are having to run the COVID race, right? My next analogy, which Don can choose to cut from this later or not, is for actually a conversation I had in the ER, trying to convince somebody to get vaccinated. Let's imagine that you're a homeowner and COVID comes knocking on your door to invade your home in the middle of the night. And if you are vaccinated, then you might be locked and loaded to identify that invader, right? As Dr. Myers just said, your body has been shown the enemy. And so when COVID comes through your door, you're now locked and loaded, right? If you're unvaccinated, if you don't know what the enemy looks like, you got to go down to the basement and scramble around for some gun parts first. And then you can have the fight, right? Whether you're locked and loaded or whether you're looking for the firearm, you're still going to have a fight, right? But I think we would all agree that it's probably better to be locked and loaded than to be down in the basement scrambling for gun parts when the fight comes.
I want to just talk quickly about this booster thing, and then we'll come into a little bit around the history of Delta variant in particular, because I think they do play into one another. So this is a news announcement from Pfizer that's now probably 6-8 weeks old, where they talk about, this thing loses a little bit of its ability to protect against symptoms, right? So partway down our previous chart, but has yet to be shown to lose anything significantly as it relates to hospitalization and death. And this is the study that came from there. And it actually is not a full-fledged study. It's more of a governmental report that doesn't have full peer review. But what you can see is that they decline against the infection rate down to about 64%. And this is where the headline comes. And you see that across all the media. Oh my goodness, we're 64% effectiveness. But they forget to come to the right line to say, oh, by the way, it's still 93% effective against hospitalization and death. Right. So that to me is the most important piece here is, yes, the Delta variant may get a little more because it's so transmissible, but it doesn't really change hospitalization and death. And to Don's point, it's never been 100%. There's no such thing as 100%, right? Next slide. And so then came this thing back on July the 9th, right? To get us all confused, July the 9th in Europe, July the 8th from the CDC. We don't need any boosters, right? That was 5 weeks ago. Next slide, right? Then they come out and say, well, never mind. We may actually need a booster. And this is where, quite frankly, people start to have lack of confidence, right? Because how can this thing change this fast? Why is this even possible, right? And the CDC mantra used to be first, be right, and be credible. I would argue they've struggled on all three of those of their parameters of late. Some of which because I think they did not appropriately put the caveats that Don was talking about. We had these vaccines in, late spring, mowing the grass, washing the dishes, curing world hunger, and oh, by the way, they prevent 100% of COVID in all situations. And we all kind of knew that was just too good to be true. And so the lack of those caveats, I think, then led us to some of these crises of confidence. We can go to the next slide, though, and say, there actually is a reason that things changed from July to August. This is the ESO data, and if you look at the EMS provider impressions to the top left of COVID disease, see where it was in July the 8th, see where it is now. You do the same thing on the hospital confirmed cases. That's the ICD-10. These were absolute COVID cases with the red line there on the top right. And then the middle line at the bottom is your deaths. And what you can see is if you were sitting in the world on July the 8th, it looked pretty good. And it looks a whole lot different now. And so I think the other piece that we, as the citizenry, are going to have to accept is this thing's going to change over and over and over again. And so we just have to take the guidance as what it is. It's true today, and we're going to keep watching for tomorrow. But our friends at the CDC can be a little bit more transparent too, and I think they've probably received that message a couple of times. We can go to the. I'm sorry, Jose, do you want to?
Yeah, we're gonna. Can you go back one slide? Brent, what are your thoughts? I mean, when and this is great data from ESO and putting this together to provide some aggregate view into what's happening just beyond sort of our region, But I'm very interested in how quickly that slopes on those curves for the last surge seem way steeper than the prior ones, and I just didn't know if you have any additional insight of that, because it's just, to me, is fascinating how we were. At the feeling things are going good. We got together July 4th and everything else, and suddenly, bam.
So two things I think are important there. Great point. So if you look let's start with the slope line. And the nice thing here is these data match the CDC almost 100%. So we can just use these data to watch national trends, and it's played through the whole time. For those that are really into data, I do want to point out we do not have New York City in here. So that very first peak is artificially low because it did not account for what happened in New York, which was basically the first peak in the United States, mostly. So there is a little bit of artificiality there, just to point that out. But that being said, you're right. Look not only at the slope, but the magnitude of those lines on both of the top graphs, right? We're almost back to where we were at the worst time in January. One thing to point out, deaths take a while to report, but even as they catch up, you're going to see the death number at the bottom is not going to look like it did in January, right? It's not going to get back that high. So the first thing is the vaccines are working in that way. The reason for the best we can tell, the reason for the steepness of that slope is it's a Delta variant. And it is moving so much faster through the population because it's, chickenpox-like transmission as opposed to flu-like transmission. And so it moves a whole lot faster. That's the best we can tell. And we'll dive into the death data in a little bit to see if we can flesh that out some. Great question. So I want to look at the National Health Service data because they've already been through Delta variant, right? We're kind of in it. They've been through it. So I just want to kind of see what they show. So what you can see off to the left here are the number of cases in the bars, and the number of dotted lines are the positivity of their test percentages, right? So, we've at 13.5% right now in North Carolina. You can see at their biggest peak there on the yellow dot, they were at almost 18% positivity when Delta was at its peak with them. When you come to the right bar, what you can see is they didn't have any flu, right? This was all indeed COVID. Let's go to the next slide. And then what you can see here is the year prior to Delta is off to the left, and the ages of infection, male versus female. And then come to the Delta and look at that 20 to 29-year-old bar, right? Delta in the United Kingdom was a disease of the young compared to the previous year prior to those few weeks of Delta that we saw there. And so what you can see, however, is that deaths stayed in the higher age group throughout all of the disease process. And the reason that this happened is the same here as it was in Great Britain. So look here, and then we'll go right back to the National Health Service. You can see that the cases off to the left sort of mirror the population, because the bars are the cases and the gray is the population. But the deaths are so disproportionately in the older age groups. So why is it we're not seeing the deaths now? Next slide. Because everybody over the age of 65 took the vaccine. So they're at 93%. You can see off to the right, this is the British data. We'll come to the American data on the next slide. But you can see you have to get way down into the 50s before you have somebody that is below 80% vaccine in the United Kingdom, right? They've got a great uptick of vaccine. Next slide is us from the CDC, and you can see the same thing. By age, the number of people that have been vaccinated, and this is till the end of July, so we've done better since August, but you get the notion, and we'll go to the latest survey at the very end and reflect on it for a minute. You can see the older age groups are more vaccinated, therefore the deaths are going down. And this is our data, at ESO. And so what you can see is we just superimpose these two graphs to really drive home the point. And again, that first bar doesn't have the New York data. But as you come across, you can see in the January peak, deaths came right up with it. In the April peak, they really didn't. And so far in the July peak, deaths are going to increase. So we know deaths have a 2-week lag, right? So that's going to come up, but it's almost assuredly not going to come up to the level that it did relative to July infections. Relative January infections, rather. Okay, next slide. So this is also ESO data, and this gives it, I think, really a good context. So we're out of July by 2 weeks. So July's done, and Delta was available. So I'll call your attention to two parts of this bar. The first is in January, just from EMS transports under, with ESO software, there were 5,300 deaths in that month. In July, there were 331, right? So we talk about, if you just look at the bar graph, which is what a lot of the media would focus on, you don't get the idea of this difference in magnitude, right? You just think, well, there's been more deaths in the younger populations because the dark blue and the light blue are the younger populations in the later outbreaks, the later peaks. But we're 10-fold difference, 12-fold difference in the total number of deaths, right? So you have to kind of know what we're looking at. So this, to me, says there are going to be deaths in the younger population, particularly in the unvaccinated, but we're not going to get to the same magnitude we did before because vaccines in general have dampened this thing down. All right. We know that this is very effective. We've already kind of looked at this. The UK data did the same during their Delta that we saw with the Israeli data. The effectiveness for severe symptomatic disease remained high. However, one dose was not very good, right? So this is the notion that you have to have both doses. And I think what we are missing in the world right now is the J&J data. There's just not good data to help us understand the protection of J&J, but the mRNAs seem to be pretty good if they have both doses. All right.
So a question on that.
Yeah.
Just, out of your gestalt, do you anticipate J&J holding up better because it's not an mRNA vaccine versus Pfizer and Moderna? Or do you know?
Don't know. I know that literally since we made these slides, J&J has applied for their booster shot. So I think they feel the same, that there's something about that 6 to 8 month window. The other thing to remember that as we look at our friends at the United Kingdom, they waited 88 days between shot 1 and 2 rather than 42. They did it for logistical reasons, but it may be that they were onto something. That the longer you pull between the two, the better that second immune response is. So I think the booster is, all of the data suggests that the shot 3 is not as good as shot 2. It's like 4 to 8 times better than shot 2.
Right, and like Brent stated, there was actually, I mean, I haven't dove into it, but there's a report this morning in the public space that talks about J&J applying for their booster shot, but also that they have some data coming out that suggests that they will follow through as well with a booster. But certainly, I'm sure we're going to hear something about it in the next couple of weeks.
So, and this may be a little bit early, but why do some vaccines last longer than others? I mean, is there a way, like, tetanus, you don't need a booster every 6 to 8 months for tetanus, right? You go longer distance for that. Is it how it's made? Is it the mRNA process? Why is there a difference in vaccines and when you need boosters and when you don't?
I'm not a virologist, but I do want to point out a couple of things that have happened in our lifetime, right? The answer is we're still learning, because if you think about the diphtheria as the prime example, right? We used to think that once you had your shot for the whooping cough, that you were done, right? And now we know that pertussis, as an example, needed to be added back more frequently than we thought because that immunity actually waned. And it may be true for other things. What's interesting here is we have such a high exposure to this disease right now, right? The community spread is so high that if there is a weakness in the vaccine, it is going to become readily and immediately apparent, which is different than a lot of the other diseases that we talk about, right? There's not a lot of pertussis in the community compared to what we're seeing here, right? And so I think there's a hypervigilance that comes because the burden of disease is so high. These vaccines, interestingly, right? I mean, we could do a lot of things now for measles and it would work pretty well because the burden of disease is pretty low, right? But when the burden of disease is this high, it emphasizes that recurrent weakness. But I'm not a virologist. Maybe others have more detail on the humoral response. I colored in that bubble on a board exam just to let you know that was still pencil and paper in a classroom when I did that part. So it's been a while.
Yeah, I'm not a virologist either, but I'll add, Don, to that by saying that characteristics of the individual diseases have something to do with it as well as obviously the underlying prevalence of disease in the community. If varicella, chickenpox is a great example, right? So you can be vaccinated against chickenpox and still get chickenpox. People think that chickenpox, inherent innate immunity that we all had when we were little, maybe a little bit more protective than the vaccine against chickenpox for folks who hadn't had chickenpox but were vaccinated. That's not necessarily true for other diseases, right? The other thing is that there are certainly plenty of examples of diseases that do require, as you said, re-up on immunization, depending on the likelihood of exposure, right? So your tetanus is good for 10 years unless you get injured with a tetanus-prone wound, and then your tetanus is only good for 5 years, right? And I think, there are also other examples of diseases that have essentially been eradicated by vaccination, right? Polio, smallpox, right? We don't actually know if we would need a polio vaccine again because there ain't no polio, right? It's certainly possible that were, heaven forbid, some of these diseases to come back, or heaven forbid somebody to use smallpox as a bioweapon, that we would all need to re-up on diseases that maybe we had or our parents had or our grandparents had in the remote past, right? So I think there's a couple of answers to that, but basically the reason for differences in re-upping on vaccines has to do with inherent characteristics of the disease itself, and how it changes and how it replicates, or is it different, year to year versus is it not? And then obviously the prevalence of disease. And we'll talk a little bit more about that in a few minutes. We talk about variants. But I'll end this piece by saying that flu is a great example, right? So flu, by the nature of how it is as an organism, changes often, right? And so we have to get a new flu vaccine every year for that reason, right? Because it changes often and because we want to be protected. And there are, large, types of flu A, flu B, we know that. But even within those flu types, we're all aware of flu subtypes that are out there in the world, and potentially the chance for one or more subtypes to be more prevalent in one year versus the next. That's just the nature of the flu virus, and because it changes so often, we have to get vaccinated more regularly against it.
And this just goes to emphasize that this can be replicated in the lab. Just to point out that the reason I put this one up is just the last bullet on the right. Vaccine provides variant protection. Natural immunity to the alpha, the original COVID from months ago, does not confer the same level of protection. So when people say, I've had the disease, I don't want to have a vaccine, that's kind of like saying I had the flu last year, so I don't need this year's flu vaccine. We're in a different variant, a different world. And so our recommendation for everyone at ESO is if you have been PCR confirmed COVID, you still take one mRNA dose to give you that variant coverage. And so you'll see there's the natural immunity is just not as strong. It's not as strong in the lab, and it's not as strong in the world, simply because of the way that these vaccines have been so efficacious.
Okay, so I want to zero in on this a little bit. And again, we may be getting ahead of ourselves, but you talked about the fact that this virus has that telltale protein spike that makes it easy to create a vaccine for. But there's still other, I think like 28 proteins on that virus. So if we think about how the immune system response works, right, with the antibodies sticking to it, T cells being able to identify, if we don't do a booster, for instance, does that allow our body to have a better immune response because it's learning more of the proteins on the virus? Or does the variants change and therefore the proteins change, which makes that sort of argument null and void?
So the way I look at this is, and again, I'm not a virologist, but the way I look at this is kind of like this. There is a signature protein sequence that causes COVID-19 disease. And these vaccines have been designed around that signature. If it mutates beyond that signature to any significant degree, it's no longer COVID disease. Right? Now, can there be a variant that would change just enough to slip past the vaccine, but still maintain this disease profile? Of course. And that's what everybody's so worried about, right? Is that in theory could happen. Historically, we can identify that, and that's where your booster changes, right? Is that you now go to this different protein sequence. But for what we know right now is that the vaccine provides a more robust variant protection than any single natural exposure. There is very, very, very preliminary data, like not published yet kind of data, that seems to suggest if you've had the vaccine and then this Delta variant, that you have very robust protection across a whole wide swath of different diseases. Not enough to put in a slide yet because we don't have the background data, but there's a signal early on that Delta plus a vaccine is just as strong of immunity as you could possibly have. Alpha alone, that original COVID with no additional vaccine, seems to provide some protection, but is not nearly as robust as you get with a single vaccine on top of it.
So is that why? So the other day on, you probably didn't see this because it was on Fox News, but the Pfizer CEO said that a COVID-19 vaccine resistant variant is very likely to emerge. Is that why?
So it's just like anything else. The reason that viruses are so difficult, right, is that they are fragile. And it's their fragility that causes them to constantly mutate, right? Because they are just not all that stable. So it is almost assured that it's going to happen. Now, we'll have a little banter here about Fox News. Pfizer gets to sell more vaccine, the more variants there are. So I'm sure he'll be thrilled if there's a clear variant that gives him another booster vaccine. But that being said, if we look back at flu and other things, of course, right? We know that's coming. The trick is, can we get it to be more like the flu, where each variant is it's a change on a theme, and some people are going to have breakthrough. But if you're vaccinated for the flu every season, you're in a whole lot better shape when the new flu comes out than the person that hasn't been doing that, right? Because your immune system at least understands in general what that disease looks like.
Yeah, I was going to add, and to the what Brent was alluding to about the natural immunity, we have to understand that the natural immune response after being exposed to COVID is very individualized, right? So it depends on how the severe course of illness, it depends on your immune system, and it depends. So that's extremely variable, and so you have to take into account that it is more predictive, more effective, the vaccination process, from a longer term sort of immunity standpoint. So just want to make sure that when folks talk about natural immunity, understand that response would be very variable. And one of the factors is the degree of severe illness you were exposed to. And number two, your ability and the health state of your immune system.
I mean, the reason I bring that up is that it's one argument that a lot of people are using as a reason not to get the vaccine. The BBC did a very good article a couple of weeks ago about sort of categorizing why people are hesitant to get the vaccine, and that's one of them. I mean, there are others: complacency, confidence overall in the virus, and et cetera. But so that's why I wanted to address that, is because I know that is one of the reasons why people are hesitant about getting the vaccine, is because there's this belief that this natural immunity will be better or more protective for them than a quote unquote artificial immunity.
Yeah, if you were diagnosed with COVID-19, it's still recommended that you get vaccinated.
So I think now we're going to wade into areas where Don's probably going to have a lot of fun, because we're going to talk about who's been vaccinated, right? And so one of the things that we as physicians often get, kind of, are we practicing what we preach? Or are we doing one of these do as I say and not as I do kind of things, right? Are we part of the vast conspiracy, right, that is saying you should get vaccinated? Well, as it turns out, next slide, 96% of practicing physicians in the United States have been vaccinated. So to me, that is the most compelling data around who should be vaccinated. The people that arguably have been educated the most around this particular thing and understand the risk better than anybody else. They've seen the allergic reactions from this and all the other vaccines. We've treated all the bad outcomes that come from vaccines. 96% of us rolled up our sleeves and went and got vaccinated, right? So I think that's just a powerful thing to talk about. Next slide.
I would also add that there's a difference between seeing it on the news and in social media and living it firsthand. It is hard to describe what it is like in an ICU or in a hospital treating multiple COVID cases. You can't really convey that in a 30-second spot in a news clip.
And Don, you've set me up for an upcoming slide, and I promise we didn't have this done, but this next slide is where I want to pause for a minute for that exact reason. People have taken this to make it a political situation, and they've talked about the party affiliations of the vaccinated and the unvaccinated and made a big deal about that. I think that's a confounder. I think party affiliation has zero to do with it. This is what it has to do with. If we go just to the very bottom, we'll come back up the rest in a minute, but just come to geography. If you think about the first outbreak of this disease last spring, summer, and into the winter, when it was not Delta and it was not so highly transmissible, It was concentrated in the urban environments because it was transmitted in that way, right? If you're in the suburbs or in the rural area, you were much less likely to see or know an individual that had been infected. So to Don's exact point, when you know somebody that's gotten sick, you're going to be more likely to get vaccinated. So this number undoubtedly is getting ready to change, and we've already seen it. Because Delta is more transmissible, then it doesn't care whether you are crowded urban, suburban, or rural, everybody's seeing the disease. And so your personal experience is leading people to get vaccinated. So I think we just make way too much of the political part. It just so happens in the United States, the political parties follow this line more often than not. But the reason and there's no data behind this other than my opinion, but my opinion is you are more likely to take action when you know someone that's been sick. Conversely, when you're treating people and all of those that are sick and dying are beyond 75 and a third of them are coming from a nursing home, it is easy to put yourself on the other side of the stethoscope and say, that's really bad, but that's never going to happen to me. When the age of death has changed, like we have seen with this Delta variant, that's the other part that we're seeing, and that comes up to the very top part of this. If you are over 65, 86% of the people have been vaccinated. That crosses all political lines, right? I mean, if we look at the demographics of parties in the United States, those over 65 are disproportionately Republican. But 86% of them have been vaccinated. Back to my argument, it has nothing to do with your political party. It has to do with, I know someone that's been sick versus I don't. And so my hope is that when we think about this for a minute, it takes us back from the us versus them, pointing fingers, all of that. Everybody's responds differently immunologically, as Jose said, but you also respond differently when you've seen somebody sick versus when you haven't. And that is changing with the Delta variant because it doesn't care about geography in any way, shape, form, or fashion. The last thing on this slide to point out is there was a focused effort from a socioeconomic and race ethnicity perspective, and I think we can say that's been successful. If you look at who has been vaccinated, again, it has to do with who's had the experience of somebody being sick, right? And so there's just a common theme in this survey that just was done this past weekend about who's been vaccinated and who hasn't. And I would argue the common theme in there is who's seen or known somebody that got really sick with the disease versus who hasn't. And that changes the way people behave. Next slide.
Yeah, I think the political thing is spot on. While you were talking, it made me think of there's a social psychologist. His name's Jonathan Haidt. He's written a couple of books. One is Righteous Mind. It's pretty good. I'd recommend it actually. But he talks about, we inherit three psychological systems from our ancestors. One is a system that protects us against foreign attacks, right? So our ancestors lived in groups, and that's how we protected each other, and other groups would protect us. And from a psychological standpoint, that would bring us together as a community. And we saw that World War II, we saw that after 9/11. We rallied around each other to help protect us in the homeland. There's what he calls a contagious response, right? So, if you think about the days of people with leprosy, right? We avoided those people like the plague, right? I mean, we've all heard that statement, and that drives us further apart. And the third thing that we inherit from our ancestors is a shortage response, right? So for them, food was not always plentiful. Sometimes it was, but a lot of times it wasn't. And so they were, hoarders in a lot of cases, right? I mean, my grandmother, my great grandmother talked about canning, and was always prepared. You didn't leave food on the table. You had to eat all of it for that reason. And that's another thing that pulls us apart from a community standpoint. And unfortunately, those two last themes are what we are experiencing, right? We're having a contagious response and shortages of things, labor, toilet paper, right? All of those things. And that's also pulling us apart. And when you have political opportunists on both sides who are more concerned about scoring points and celebrating when things go bad. It is no wonder why we are in the situation where we are now, and we start to not trust the systems that are in place, and we stop trusting each other.
And Don, that's a great point. The part I didn't put on this slide from this survey is there are only 13% hard no's, right? Which means we can vaccinate 87% of the population. And if we vaccinate 87% of the population, this thing's over, right? So this notion that there's this huge, number of people, I mean, 13% is a lot of people, I get that, but 87% would get us there. This is my last slide. And I think this gets to everybody's frustration, right? Is we cannot live in the bubble off to the left forever. And I think, when the history books are written, people are going to look back and wonder about how long lockdowns were, what drove the lockdowns. There's a lot of armchair quarterbacking that's going to get done there, right? And fair enough. That being said, you will note, and in the chart I had at the very beginning when I gave that talk 6 months ago, when I had hospitals are full, deaths are disproportionate, where I had the question marks in lockdown in this deck, I had absolutely we're locking down 6 months ago. There is no way, right, that's going to happen today. It's just not going to happen. So we might as well just get past that. That's not going to be the thing. The question is going to be about this mask business and how temporizing it is, and I'm not even going to touch that with a 10-foot pole because I have my own very strong biases about that I don't want to introduce. But what I do want to say is that people can't live life like that forever. Conversely, right, we cannot just simply drive off the cliff like Thelma and Louise and just say, oh, whatever, there's nothing to be done here. And so I leave this slide to go back to the very beginning, right, of my part of this thing. It's not a complicated story. Get the vaccine. That's what is the reasonable response to the risk that we are seeing, is to be vaccinated so that we can all return to normal. It's just that simple. It doesn't have to be more complicated than that. And I'll hand it over to Jeff, but thanks for having me back.
Yeah, I'll follow up and say the same thing, that the reasonable response to risk is to evaluate the benefits of whatever the action is versus the risk of whatever the action is. And I hope that this sounds familiar to our Wake EMS colleagues and certainly the folks in the academy that I talk about this with all the time, right? And we even talk about it at Release to Practice. When you do anything in medicine, you are evaluating the benefit of doing that thing, of doing that procedure, of giving that drug against the risk of either doing it or frankly of not or not doing it, and you come up with an individual answer. And that's certainly where we are in this thing, and in this pandemic. And I think that it's absolutely a reasonable response to the risk at hand to be vaccinated, right? And hopefully we can convince you of that if you're not already. So there are some facts and challenges associated with the pandemic. Obviously, the first is that the science is changing frequently, right? This is an illness that we've known about for less than 2 years. Essentially, has been studied heavily for less than 2 years, and we know that there are many other areas of medicine that also change over time that we've known about and studied for 20 years or 30 years or 50 years. And so just the volume of new science is challenging. And yes, some of it is conflicting, right? I read a study a couple of weeks ago that I was seeing folks pass around about the natural immunity thing. Is natural immunity better than vaccine mediated immunity? I read another study 3 days later that said exactly the opposite thing, right? And so I think we know, and frankly, we've taught all of you how to evaluate the medical literature and say, what are the pros and cons of doing a particular study this way what's the PICO question, right? What's the population involved here? What's the intervention? What's the comparison group? What's the outcome if it's a comparison type study? And more importantly, when was the study done? Who was it done on? What were the circumstances surrounding it? All of those things are how a study gets to a given outcome, and doing things in slightly different ways certainly can lead to different outcomes. That doesn't mean that one finding is any less valid than another, but it means that the science is changing, and it means that every week we're learning new things, and we need to take the new information in and ingest it as best we can, while also understanding where the old information came from and the context in which those studies were done in the past, right? I think the other challenge, I'm not going to belabor this too much because we've already introduced it. Variants are a thing. We're going to talk a little bit about variants here in a few minutes. This is not a new conspiracy, right? This is not Pfizer, tossing a new variant in the wild so they can get more vaccines, right? The fact is, this is not this virus right now is not your father's Oldsmobile, right? This is a different thing than the COVID disease that we saw a year ago, and we'll talk about that a little bit. Vaccines are safe with few adverse effects across millions of doses, right? So we know that you can have an adverse reaction or even possible allergy to the vaccine, right? Those of you who worked at PNC and gave those, hundreds and thousands of doses saw that with your own eyes, right? I think that that's been borne out in both the original EUA studies and certainly in follow-up studies. And you can go to the CDC right now and look and see that of the 360 million doses of vaccines that have been given, yes, there have been some folks who have had an adverse effect, at least a short-term adverse effect. I think 9 months in, we can get into the semantics of what's long-term and what's not. But there are some short-term effects. I will say, though, that again, from a risk-benefit calculus standpoint, vaccinated folks are less likely to have significant disease, less likely to be hospitalized, less likely to be ventilated, and less likely to die, right? And so your own personal calculus needs to be, what is my, risk tolerance to the chance of an infinitesimally small adverse reaction of vaccine versus a real risk of having a bad go of COVID, or frankly, of giving it to someone else who's going to have a bad go of COVID, especially in the setting of the Delta variant. Don, you go to the next slide.
I was just going to add two things that I think are important that you said. There's a difference between misinformation and conflicting science or evolving science. And people need to learn to be able to spot the difference between the two. And sometimes that's hard. And I think it's very important when you talk about a risk benefit that you talk about all risk. I think part of the problem is we talk about COVID in relation to flu-like symptoms. We don't talk about it in terms of the long-term health effects that it causes. So, people go, oh, well, it's just flu-like symptoms. I'll get sick, I'll get better. But we don't talk about generally, the damage that it is doing to people's lungs and the long-term side effects of that. And I think that is a discharge.
I think part of the reason we don't talk about long-term is that we haven't had a lot of long-term, right? We've had 9 months. But in 9 months, we for darn sure know about people who are recovering from being in the ICU 8 months ago, people who have had pulmonary emboli that I've frankly diagnosed, who are going to have decreased cardiac and pulmonary function for the rest of their lives. We even COVID pneumonia in the 6 months since you've gotten discharged from the hospital, your lung function is never going to be the same. We just know that but we don't know never yet. We know 9 months, right? So I think sometimes that gets glossed over a little bit. To the point about new data every week, I wanted to have the most up-to-date stuff I could find for you. So this is from yesterday. This is data from a study that looked at the protection of vaccines, both in the presence of Delta and over the longer term, for frontline healthcare workers. And the punchline is that folks who are fully vaccinated pre-Delta were about 91% protected, right? And that's similar to the data in those original EUA studies that we talked about last time. Since Delta has predominated, you are about 2/3 protected, 66% protected. Go to the next slide, please. The background on this is a cohort of frontline workers, so your colleagues in several U.S. states, right? Not England or India or anywhere else. And these are healthcare providers that are being tested weekly, both from a surveillance standpoint and also if they have symptoms. These are Moderna and Pfizer vaccines, and that overall effectiveness, which is what we've talked about a little bit earlier in the video, is over time from December to now about 80%. Which is right there in the middle between 90% at the beginning when we're talking about alpha and sort of original COVID, and now 66% when we're talking about a predominance of a virus that's slightly different. 80% of these infections were symptomatic, yeah, right? So yes, we're talking about a few that we picked up that were asymptomatic folks, but 80% of these infections in this research were symptomatic. This is consistent with the study that Brent mentioned. I think it's the same study Brent mentioned a little while ago, which is the experience of folks in England, right? Fully vaccinated are about 80% protected from the Delta variant over time. Since we've started, examining large numbers of vaccinated people, right? So I think the point is, yes, the science is changing. Yes, there are, tweaks a little bit here and there and a few what ifs here and there. But in general, the body of evidence is consistent that vaccines are protective, that Delta is not good, that vaccines protect against Delta. But yes, we are concerned about, might there need to be a booster, might in the future, would there need to be a new vaccine or annual vaccines? We don't know that yet, but the body of evidence is consistent across the board that in general, vaccines are helpful and protective both against original COVID as well as Delta. Similar report again yesterday, right? So trying to get you the latest and greatest here. This was some work that looked at hospitalizations, infections hospitalizations in LA from May of this year through July of this year. I've put the titles up so you guys can look these up by yourselves if you want to. Certainly we can find them for you if people are interested in reading the details. And what you're seeing there, and the punchline here of this work is figure 1 from that paper that talks about age-adjusted rolling 7-day COVID infections and hospitalizations by vaccination status, right? So the theme of the back half of my talk here is I want to compare, frankly, relatively bluntly, folks experience who are vaccinated to folks experience who are unvaccinated, both over time and in the current frame of Delta. So on July 25th in LA County, which is just now a month ago, unvaccinated people were about 5 times as likely as fully vaccinated people to become infected. Unvaccinated people were about 29 times as likely as vaccinated people to be hospitalized, to go into the hospital, to have to wear oxygen, potentially to be intubated, ventilated, all those things. And why is that, right? And why is that? And I want to talk a little bit about variants at this point. What is a variant and what are we seeing here? What this graph is showing you, and this is a figure out of that same study, is that from May to June to July, we have seen a relatively rapid rise in a new type, essentially, of virus. Again, I'm not a virologist. I'm probably going to get some of the, dictionary virology definitions wrong here when I talk about type versus variant versus whatever else. But the bottom line is, and we'll show this in the next slide, but stay here for 1 second, Don. Viruses change over time based on essentially how they replicate and changes when they replicate, right? Viruses are tiny little particles that replicate billions and billions and billions of times, many times faster than humans, obviously, over generations and generations and generations of virus. And as they do that, the genetic code in that virus, the DNA, the RNA, depending on the illness type or depending on the disease type, changes. And as that genetic code, as that base material changes in an organism, different characteristics, right, or different phenotypes, if you will, to use the genetic term, occur, right? And so as we move from having a lot of alpha to having a lot of delta, a virus acts differently. And a virus can be more contagious. It could be more severe. It could change the way that it's shaped, right? Or it can change its ability to be suppressed by a given drug, right? Or a given vaccine. And so the purpose of just showing this graph is to show you that indeed the virus has changed, and certainly in LA County and in many other areas of the country, including our own area, because we see when we sample virus types from people who are infected, the genetic code is different, right? And we name those things differently. We name them delta, gamma, lambda, whatever it is. When we see genetic code, when virologists see genetic code that's different, they name it differently. And then what we see as a response to that in the community is that the virus acts differently and infects people differently. Where are we at, right? Let's go back to the 1850s here, right? And all of that stuff I just said on the previous slide, we all learned about in high school biology when we learned about Darwin and his finches, right? So there's some finches in the Galapagos Islands, and they got different shaped beaks, right? And the reason they got different shaped beaks is because they eat different food from a different level of the tree. And the finches over time, over generations, over potentially years and years and years and years and years, because that's the the lifespan of a finch, right, is not minutes like a virus, but some years, right? The finches who are more adapted, more able to eat a particular nut or a particular fruit or a particular whatever based on their beak shape were more likely to survive, right? This is natural selection. This is the theory of natural selection, right? In virus terms, what's happening is Darwin's finches, but at a much faster, much more compressed rate, right? So I said that finches live a few years. I don't actually have any idea how long finches live, but they live long enough to get studied, right? People live, 80 years, right? So it takes a long time for natural selection to happen in people. Virus particles live for minutes or hours or days, and there is billions, trillions, quadrillions of them in a given person, not to mention across a population. So as a virus replicates rapidly, the likelihood of changes in the genetic code of a virus, of that organism, dramatically increase, right? And those random errors in reproduction cause the virus to act differently phenotypically. So what does that mean? Variations in a virus are selected because they survive, because they are more likely to get into your cell. The protein shape maybe changes, right? Do those viral particle survivors make the virus more contagious, more likely to pass on to one another? Are they more resistant to vaccine, right? We're starting to figure some of this out about COVID in particular. So, again, what you're seeing in that top graphic there is that the parental strain, or sort of the original COVID, if you will, just thinking about this broadly, replicates billions and billions of times, and those slight changes, those mutations in the RNA of the virus make that variant, make that next type of virus act differently. And what the graphic is kind of showing you there is one example of how that may be, right? It may change that spike protein, for example, just slightly, right? Just slightly, so that a vaccine is still effective, but slightly less effective at getting rid of the virus, right? Or at preventing the virus from replicating, or preventing the virus from being transmitted. So that's, going back to sort of the beginning of the slides, my section of the slides, that's what we're seeing to some extent as we see waning vaccine efficacy because of the Delta variant, right? Early on, 90% rocking and rolling, doing the thing. These were the EUA studies that we all looked at. And then over time, from an effectiveness standpoint, we see some level of waning protection because probably for this reason, right? Changes in the virus slightly due to variation, and as well as lots of other sort of environmental factors. So bottom line are the bullet points at the bottom of this slide. Increasing vaccination means increased protection, right? Which also means decreasing infections. It doesn't mean they go to zero, but it means decreasing infections. It means decreasing transmission person to person. It doesn't mean it goes to zero, but it means decreasing it. Decreasing transmissions means decreasing replication, decreases in variants, and hopefully holding this thing to a dull roar, right? We are trying to put out a small fire. Well, it's already a big fire now, unfortunately, but we were trying to put out a small fire before it became a big fire. Now we're trying to put out a big fire before it becomes an inferno, and there's still a chance to do that. Decreasing variants and decreasing viral change means that vaccines will continue to work. It means the monoclonal antibodies that I have to give, right, to a person who's unvaccinated who comes to me with COVID, because I can't vaccinate them at that point and have it be effective the next 2 weeks. It means those treatments can keep up, right? Those treatments continue to work, and hopefully keep up with the virus. And obviously effective vaccines and effective treatments over time spread broadly means the end of the pandemic. Next slide, please. So I just want to close with some local data. So this is Wake Med from yesterday and the day before. They get these numbers at the turn of midnight. There were 175 COVID positive hospitalized patients at Wake Med. 157 of those are unvaccinated. There were 44 COVID positive patients in the ICUs. 38 were unvaccinated. There were 26 COVID positive patients intubated on a ventilator, critically ill, and 21 of those are unvaccinated. There's a crowd out there that's watching this right now and saying, yeah, but are these all people who are hospitalized because of COVID? Or are they in the ICU because of COVID? And I want to tell you two stories that hopefully will help you out with this. The punchline up front, the bottom line up front, is that yes, there are some onesies, twosies, threesies, foursies in here that are admitted because of COVID, or sorry, not because of COVID, but happen to be COVID positive. The vast majority of these who are counted this way are admitted because they have COVID illness and are being treated for that. And I'll tell you a couple stories. So I've admitted, I don't know, probably 10 or so of these, my own personal self. One of them I admitted was a breakthrough infection, if you want to call it that. It was a nice 75-year-old lady, and she had been vaccinated early on, and she, clearly for the last 3, 4, 5 days had been suffering from a breakthrough COVID infection. She was not particularly short of breath, but she was extraordinarily fatigued, and she was a little bit dizzy and a little bit woozy. She had been throwing up a little bit, and she was, a little bit dehydrated when I saw her. And she basically came to the ED, frankly, because she fell. So she was getting up to, feeling poorly in the middle of the night, got up, fell, cracked her head on the side of the bedside table, and bled out about 2 units because she's on Xarelto. So she got admitted to the hospital for anemia, feeling woozy, syncope, and yeah, she was COVID positive. So you tell me, I don't know, does that count as a COVID admission or not? I think the reason that she fell was because she had a breakthrough COVID infection. But if she hadn't have fallen, she'd have been just as fine with her breakthrough COVID infection at home, right? So yes, that person is in these numbers somewhere. The other story I'll tell you is from yesterday. I saw a woman who had a COVID exposure, and she had some nasal congestion, and she has asthma. She also, unfortunately, she weighed about 400 pounds. And she I saw her, she was a little bit wheezy. Her SATs were okay. And I treated her for her asthma, and I tested her for COVID because of her exposure to her neighbor's kid, I think. And she came back positive for COVID. And we did her ambulatory SAT, and it wasn't great. It was in the high 80s, low 90s. And we kept treating her for her asthma over a period of a few hours. and she would get better with nebs. And then, as asthma sometimes does, it was a little refractory, and I couldn't, turn her all the way around in 4 or 6 hours. And so I decided to admit her. Now, I would have admitted her whether or not she was COVID positive, because she has, decent asthma, and her stats weren't great. Was COVID contributing to that? I have no idea. Is she at a high risk because she is unvaccinated, because she is morbidly obese, because she has asthma, of being one of these patients in the ICU a week from now? Absolutely she is, right? I want to end this slide by saying that there are some onesie, twosie, threesies in here who happen to be admitted to the hospital who are COVID positive and are admitted not necessarily because of COVID, but for reasons like the ones that I just suggested. That does not decrease the burden of any of this on the healthcare system, because whether or not you're admitted because you have bilateral COVID pneumonia, or whether or not you're admitted because you fell and hit your head, you have to be cohorted separately. You probably have Delta variant, which means it's extraordinarily contagious, both to healthcare workers who are vaccinated and your co-patients. And COVID will likely, increase your chances of having complications from whatever your underlying disease process is. So that's my take on the whole COVID hospitalization thing. And it's interesting to me that these statistics, 90% of hospitalized patients are unvaccinated who have COVID. These statistics, it's interesting to me, mirror the protection statistics that we see essentially with vaccines, right? You can't, that's a little bit of a false equivalency there. But to me, it further supports the notion that vaccines don't fix everything. Nothing's 100% in medicine, but they're pretty darn effective at making you more likely to win your race, right? They're making you more likely to win your race, to win your fight, when and if COVID comes knocking at your door. So to me, the summary and the take home at this point are that vaccines are not perfect at preventing and eradicating COVID yet. We hope that they are. We hope that we can get to a point where we've tamped down transmission enough so that we can make it go away completely. But we are 100% sure that increasing the number of people vaccinated does decrease infection, decrease transmission, decrease burden on the healthcare system. So even if you're healthy, I'll encourage you to do this for your family, for your immune compromised friends, for your EMS colleagues. And certainly for your kids, right? I've got 2 kids who are unvaccinated because it's not approved for them yet. And I'm really hoping that I don't bring Delta home from the ER and give it to them. We want to reduce our chances of having an ongoing situation where we're transmitting virus and we're continuing to see concerning variants pop up. And then lastly, do it for you. Yes, if you are young and healthy and you get COVID, the likelihood of you doing well is pretty good. But we know for sure that we can't predict who is going to have a bad go of it. And we do know that vaccination, regardless of who you are, young, old, healthy, unhealthy, vaccination decreases hospitalization, severe illness, and death. Young and healthy people are in the hospital. I've admitted some, and you don't want to be that statistic.
One thing we hadn't talked about, we briefly mentioned, but one of the vaccines now has full FDA approval. What does that mean? What extra did that vaccine have to go through to get that approval?
I'll be happy to weigh in on the first part of that. Not a whole lot. The honest answer is that with the number of vaccines that have been administered, simply reporting on what happened between the EUA and the time of the full approval is all that was required, because there's nothing that has changed, right? So for some drugs, they go into this first trial and they have their phase 1 and their phase 2, and then they hit the big population and something totally unanticipated happens, and there's a whole hullabaloo at the FDA where you have to go back and look, was there a signal of it in the early, and all of those things go on. For these, none of that has happened, right? Because they have behaved in the millions like they behaved in the thousands. So they didn't have to really do a whole lot. So I'm not trying to imply the FDA didn't do a thorough review. I'm saying there was not a whole lot of additional types of data that were obtain because they were already monitoring everything. It just so happened they could go, and again, people will say, oh my goodness, it was too quick. Administering 200 million doses of anything, you can figure out if there's a problem. That's pretty easy to do. So I guess maybe the most appropriate way to say it is all they did is continue the monitoring that they'd already started, and they didn't find any surprises, and they've gone through as many patients as they needed to. I think Moderna will be right behind. J&J may be a little bit longer, and the reason is, as you know, it had some bumps in the uptake. So there's not been millions and millions and millions and millions of J&J doses. There's been like 14 million instead of 200 million, right? So there's going to be maybe a little bit of delay there, but nobody should read anything into that other than just the volume of administration is a little bit less.
Yeah, I would just chime in to say, Don, if you pulled up my slides from the original talk that we gave, I compared, what it takes to get EUA versus to get full approval. And the answer is time and volume. That's it, right? So it's more patients and more study of the thing, right? And there's a statement, I'm not going to get exactly right, but it talks about the volume of evidence, sort of beyond the shadow of a doubt, versus from an EUA standpoint, you have a pretty darn good idea, but you don't have the volume of evidence sort of beyond the shadow of a doubt. And so at this point with Pfizer, we have the volume of evidence and the volume of doses, beyond the shadow of a doubt to say that the benefits of this vaccine, dramatically outweigh any possible risks of the vaccine, at least on a population basis, right? If I'm gonna make a joke here, just warning, flag, trigger warning here for a joke, but if we had all gotten, me and my colleagues and all of us on this call had grown a third arm, after 3 months into getting Pfizer, you can be guaranteed it wouldn't have gotten full FDA approval at this point, right? But the reality is that they monitored this extraordinarily large volume of doses over a longer period of time, and as Brent exactly just said, there was no signal abnormality. There was nothing new that popped up, nothing surprising that happened, and so we were able to go ahead with full approval.
And that was one of the arguments that some people are using against getting the vaccine, is that they were waiting on full FDA approval. And I think the take-home message is there's really nothing special between what we had and what we have now, maybe more psychological than anything. What do you say to those people? Because this is the other thing I hear is, we still don't know the long-term side effects of this. And so we don't know what we're putting in our bodies. There's the whole conversation about, could it in some way affect the ability to reproduce? How do you get, or can you get those people across the finish line? What would you say to those folks to try and convince them to get the vaccine?
Yeah, I was going to say, here's the thing. So we do know that of published evidence that female patients that actually were not vaccinated and actually suffered from COVID had way more, adverse complications from the disease process than people that actually were vaccinated. So I don't, in the actual societies from gynecology, the American Academy of Obstetric Gynecologists, actually, they do recommend vaccination. I still don't understand sort of the concern of what effects would have from just the basic understanding on how vaccines work that actually would affect long-term any effects of that matter. I don't know if you, Brent or Jeff, have any other additional thoughts on that.
The only thing I would add is that I think people have conflated this notion of mRNA somehow with interfering with the ability to reproduce. And remember, this is just a messenger RNA that has your body make a protein and is gone, right? It doesn't enter your genome. It doesn't interfere, with any of the reproductive, physiology of any kind. It simply it's elegant in its simplicity, right? It's just go in, make this little protein for me, and then the vaccine's gone, the protein's circulating, you make antibodies, and we're done, right? It's simple. It's no more and no less than that. So I think when people see mRNA and DNA, there's this, particularly in the non-scientific social media sphere, it gives you a place to kind of hang your hat to say, oh, well, while it's doing that, it's going to interfere with all these other things.
Yeah.
The other thing, what we do know, though, is that if you are pregnant and you become infected with COVID, you are multiple times more likely to lose that baby and have a bad outcome. So we can argue the theories of, mRNA, which has nothing to do with anything, but we know for a fact that infection while pregnant is a really bad problem. And so people that are pregnant ought to get vaccinated.
Yeah, and Don, I would just add, to answer your question in terms of how do you convince folks, I try my best. I would try my best to come back to remembering that certainly not everybody who we're trying to convince, had a science education the same way that I did, right? So I think to me, it's about trying my best to explain how immunology works. And I think this gets to the kind of argument, I guess, also about, well, I trust my own body. I trust my body's immune system. I don't want to trust, this other vaccine. I want to come back to the vaccine is your body's immune system. Your vaccine is using your body's immune system. You are making sure with some prompting from an external injection that your body's immune system can respond, right? So when your body's immune system responds to whatever the illness is, it is you. It is your body systems. It is your T cells. It is your B cells. It is your immune response that is acting to destroy the invader, right? All the vaccine has done is briefly, temporarily taught your immune system what that vaccine or what that invader looks like. That's all it's done. That's all it's done. It doesn't hang around. It doesn't stay there. It doesn't contribute anything to the fight, frankly, right? All we've done is tell your immune system, this is how you need to act when you see this.
And Don, I would also offer, just lastly, I know we're close to the end, but I will also offer that, it is okay to have questions. It is okay to have concerns. We are more than available if somebody wants to have a more private conversation about questions to reach out, and we'll be more happy to go through it. But we would not be here as your medical directors, as physicians, as your colleagues, as your friends, if we did not think it was a safe, right thing to do for you, your loved ones, and your patients to be vaccinated. I know we're trying to simplify some of these concerns, but really there's no correlation between how vaccines work and how the mRNA process was very innovative from a scientific standpoint and the potential effects of fertility reproduction concerns. But if somebody wants to reach out, we're more happy to kind of go into that and more in depth.
And we will leave it there. Thank you all once again for your time and your expertise. And as Dr. Cabanas said, if you have questions, please feel free to reach out. And we do reserve the right to get together again and do another one of these if necessary. Hopefully it won't come to that. So thank you all.
Thank you all for all your hard work out there in the field. Thank you for all your care for patients. And if anything, please let us know. Thank you, Don, for putting together.